I want to mention and
Yeah.
build up on what you just said on Hodgkin. I mean, the response rate is very impressive comparing to other lymphomas. And actually, your point of the PD-L1 and PD-L2 or PD-1 ligand, and in Hodgkin are overexpressed typically and resulting from amplification of 9q24. That is very classic in Hodgkin lymphoma. So we believe that this is really the reason why Hodgkin lymphoma cells respond and Hodgkin disease cells respond very well. One of the interesting questions in that setting, though, is that when you try to look at reasons why patients, you mentioned melanoma first approval, is that the mutation load is very important for the response to, and the more the cells are mutated, the more immunogenic the cells become. And what's your comment on that?
So I think just to talk about what that concept is. So we know that various kinds of malignancies can have higher mutational loads. On one end, on the lower end, are actually malignancies like acute myeloid leukemia, which if you look at map along the genome and you say how many mutations are occurring per a certain stretch of the genome, so and there have been really elegant studies that have looked across large numbers of patients with large numbers of malignancies saying how frequent are various what we call somatic mutations that can lead to changes that can be recognized by T cells. It appears that the frequency of those things along these somatic mutations along the genome in cancer cells does appear to be associated with their ability, at least in solid tumors, to respond to checkpoint inhibitor therapy. So on one end of that mutational spectrum, that is with higher somatic mutation load, are lung cancer and melanoma. Again, on the other end of the spectrum is acute myeloid leukemia. It looks like, again, when we're talking about the lymphomas and CLL and myeloma, they're intermediate between these two extremes. So I think that we actually need more data about how mutational load drives responses to checkpoint inhibitors. We know more about that in the solid tumor setting than in the
melanoma, clearly correlated with the duration of response.
But Fred, let's get you in on this. I mean, you know, they're B cells, right? So, but there's striking differences between Hodgkin's disease and multiple myeloma. Is it all just the mutational differences, or is there a microenvironment? Or tell us a little bit about that.
Yeah, although the response rates in solid tumors do seem to correspond to some degree to the mutational rate, for hematologic malignancies, it's not clear that that's going to hold up. We talked about Hodgkin's disease and the 9p24.1 chromosomal translocations that are amplifications actually that are common and drive increased expression of PD-Ligand 1 and PD-Ligand 2 on the Reed-Sternberg cells. So that doesn't have to do with mutational rate. It has to do with expression likely of the ligands for these checkpoint antibodies. It's unclear for other hematologic malignancies whether PD-1 or PD-Ligand 1 expression is going to be what drives the responses. We know for solid tumors that the expression of PD-Ligand 1 on the tumor or within the tumor microenvironment can correspond to responses. So by immunohistochemistry, looking at the expression of these markers. However, it doesn't function to rule patients out for these therapies for solid tumors. Patients can have robust anti-tumor immune responses even if they don't express PD-Ligand 1 or PD-Ligand 2. So it's early days for hematologic malignancies, and we really need to do more work. In addition, different hematologic malignancies have different immune infiltrates. Diffuse large B-cell lymphoma has a homogeneous infiltration of large B cells. Whereas Hodgkin's lymphoma, there's very few and rare Reed-Sternberg cells, and there's an infiltration of many different, a heterogeneous immune infiltrate. And it's likely that that heterogeneous immune infiltrate suppresses a natural anti-tumor immune response, and perhaps we can turn that back on.
Even in follicular lymphoma, right, there's different infiltrates that have been associated with different prognosis, and maybe there's a lot to be learned there about what's going to be the most responsive group and perhaps how to change that.
Yeah.
There hasn't been that much data yet in follicular lymphoma. As you said, you would expect that you would have good response. So there's been combination with pembrolizumab and combination with rituximab in patients that were not rituximab refractory. The CR rate was impressive in that setting, more than you would expect maybe. But it's still early, and I agree with you that it will be interesting to see if the different type of microenvironment, more macrophage pro-tumor effect versus anti-tumor effect, more T-cell driven, and if that would affect the response. I think this is a real, where you can see this and feel this at ASCO. It's a very hot topic, finding biomarkers and understanding better what's the signature that corresponds to response and durability in checkpoint inhibition.
The other comment I would make is that you talked in your introduction about the importance of allogeneic transplantation. It's really a lesson for how immunotherapy can work. And we know that in the context of allogeneic transplantation that there have been some surprising developments. We started off doing allotransplants for acute myeloid leukemia primarily, but we learned that really with very minimal intensive chemotherapy and the use of non-myeloablative transplantation, we could easily cure follicular lymphoma. On the other hand, if we look at myeloma, the immunologic responses in the allogeneic transplant setting for myeloma clearly are much less, and we depend on intensive chemotherapy. That's often really been a barrier to greater success. So I think that even though the principles for how an allogeneic transplant response works against myeloma may be different than how it works against follicular lymphoma, that there may be some parallels about immunogenicity and the success of those tumor responses that may be common principles that we have to learn about.
Well, I think it's very exciting about this whole aspect of checkpoint inhibition is that we're going to go later on during the discussion in combination, dual inhibition, etc. But the fact that some of these responses are very durable and you can actually stop the treatment. Comparing to a lot of small molecules that you have to keep for years until progression, here you can have patients achieve a CR very quickly and have a very durable response. The first patient that was treated with ipilimumab has been in remission for 10 years. So this is really important.
Wow.